Hey, we're back with another great coding case, so Hapy Codemas, let's get into it.
So our pre-op diagnosis and post-op diagnosis are the same: intrauterine pregnancy at term. Procedure performed: primary low transverse cesarean section. We have our anesthesia, estimated blood loss, and complications. Findings: female infant in cephalic position, OP position, weight is 9 pounds 8 ounces. APGARs were 9 at 1 minute and 9 at 5 minutes. Normal uterus, tubes, and ovaries were noted. Patient is a 20-year-old gravida 1, para 0 female. So the gravida is the times the patient has been pregnant. Para is the number of times they've given birth. So she presented to labor and delivery in early active labor at 40 and 6/7 weeks gestation. Patient progressed to 8 centimeters, at which time Pitocin was started. She subsequently progressed to 9 centimeters, but despite adequate contractions, arrested dilation at 9 centimeters. Decision was made to proceed with a primary low transverse cesarean section. The procedure was described to the patient in detail, and then they're basically just saying that they got consent from the patient here. Patient was taken to the operating room where epidural anesthesia was found to be adequate. The patient was prepped and draped in the usual sterile fashion in the dorsal supine position with a leftward tilt. A phenylstein skin incision was made with the scalpel and carried through to the underlying layer of fascia using bovie. The fascia was incised in the midline and extended laterally. Using Mayo scissors, kosher clamps were used to elevate the superior aspect of the fascial incision, which was elevated, and the underlying rectus muscles were dissected off bluntly and using Mayo scissors. Attention was then turned to the inferior aspect of the fascial incision, which in similar fashion was grasped with kosher clamps, elevated, and the underlying rectus muscles were dissected off bluntly and using Mayo scissors. The rectus muscles were dissected in the midline. The peritoneum was bluntly dissected, entered superiorly and inferiorly with good visualization of the bladder, because we want to make sure that we don't accidentally nick that while we're in that area. The bladder blade was inserted. The vesicouterine peritoneum was identified with pickups and entered sharply using Metzenbaum scissors. The incision was extended laterally, and the bladder flap was created digitally. The bladder blade was reinserted. The lower uterine segment was incised in a transverse fashion using the scalpel and extended using manual traction. Clear fluid was noted. Infant was subsequently delivered atraumatically. So there we go. The nose and mouth was bulb suctioned. The cord was clamped and cut. The infant was subsequently handed to the waiting nursery nurse. Next, cord blood was obtained. So that's something that the patient personally requested for cord blood donation, and that took several minutes to perform. Subsequent to the collection of this blood, the placenta was removed spontaneously, intact, with a 3-vessel cord noted. The uterus was exterized and cleared of all clots and debris. Uterine incision was repaired in 2 layers. Hemostasis visualized. Uterus was returned. They cleaned the abdomen. It was irrigated. Uterine incision was re-examined and noted to be hemostasis. Rectus muscles were reapproximated to the midline, so basically they're just closing her up here, staples, and stating that she was taken to the recovery room and in stable condition. So we're going to code for this cesarean section. We did validate this. I haven't done OB in a while, and I'm not sure about the cord collection, so that's actually something I had to look up, and I'll go over that as well. So for our OB deliveries, we want to check in our female genital system, and you're going to want to look for your maternity care and delivery. So here is our vaginal deliveries, and here are our cesarean deliveries. So that's where we want to be, the cesarean delivery section. Now here are our cesarean delivery codes, and I wanted to note that there are codes for what we call a VBAC, a vaginal birth after cesarean, or for when a patient has a cesarean delivery after a vaginal delivery, so delivery after a previous cesarean, but this patient is just having a cesarean delivery, and just by the indication that she's gravida 0, we know she hasn't given birth previously, so we're just looking at these cesarean codes. So we have here routine obstetric care, including antepartum care, cesarean delivery, and postpartum care. So we're going to assume for the purposes of this case that I went back into this patient's chart and saw that they had that antepartum care, meaning that they had visits with the same provider that delivered this baby via cesarean, and they are also providing the postpartum care. Now, if this is a provider that's not in the same group, that maybe they were received the cesarean from someone else, maybe there was a different group doctor on call during that time, and they just had the cesarean delivery, and that provider did not provide any of the prenatal care or postnatal care, this is what you would bill, the cesarean delivery only. But we're going to say that this provider did also provide the prenatal postnatal care, and that is the whole global package. So this gets reimbursed significantly more, you can manage, because it's the entire maternity care versus just doing the delivery or just doing postpartum care and delivery. So for this case, we're going to bill assuming that they provided all the maternal care, 59510. So that's what's billed when we confirm in there that they did the whole package, that we can see that they did those prenatal visits, they are doing the postpartum visits. And I do want to mention that there are some insurances that do like you to break it up, particularly some of your medical assistance programs. So do be aware that they sometimes have their own specific programs that they want you to bill specific ways, but I'm not going to do insurance specific today. This is just a general coding sample. Now, when I did a little bit of research, and by research, I mean Googling, into this cord delivery thing, what I found out was from a lot of the insurances and directives that I saw, it's saying that you can bill an unlisted code, the 59899, but chances are good this patient's insurance is not going to cover it, and that's why it kind of down here seems like the patient's request for cord blood donation. So in that case, getting that cord blood, we can probably bill this out separately just to the patient. We can try to submit it to insurance, but chances are good they're going to say, hey, this is an unlisted code. We want to see this note and see what the heck it was, and they're going to read it and go, oh yeah, this was cord blood. That's something that's not covered for us. I think if I remember correctly, it's not something that Medicare pays for, but with Medicare and obstetric care, they tend to be a little bit lacking, or at least historically have been. I haven't kept super up to date on their latest with OB care. But yeah, this is something we would probably, that would probably be patient responsibility. Now, next we need a couple of different diagnosis codes, right? Now, we need to use our diagnosis to justify why the patient had that cesarean delivery. And there really isn't a good diagnosis code for arrested dilation. The best we can do is failed trial of labor, which is pointing us to 066.40. So here 06640, failed trial of labor unspecified. It definitely wasn't the attempted vaginal birth after previous cesarean, because this was the patient's first pregnancy. And it says here, code first, rupture of uterus if applicable. That wasn't this situation, so we're going to use the 066.40. And then we need our outcome of delivery. So this was a single live birth, the Z370. So in this case, we have the CPT code for the cesarean delivery, the whole package. This will probably have to get billed out separately to insurance, or maybe we could just wait for the denial and then put it over to patient responsibility. And then here's our failed delivery, and then our outcome of delivery. It was a single live born newborn.
I hope you found this video helpful. If you did, I'd really appreciate it if you would support me in the channel by giving it a thumbs up. Don't forget to subscribe and make sure you hit that notification bell if you want to get alerts when I post new episodes. I will see you in the next episode, and until then, you just keep on coding on.